Okay, so welcome. My name is Jonathan. I have the amazing privilege of serving as data lead for the Canadian Alliance to End Homelessness. And I am both the moderator and a speaker in this session, the first one that we are having dedicated to homelessness data mortality, at homelessness mortality data, which is a subject that is immensely important, and I am very, very excited that we're having this. I want to start us with, of course, those things will happen, the land acknowledgement. So we are here in the traditional, in the unceded traditional territory of the Algonquin Anishinaabe, and the people of the Algonquin Anishinaabe Nation, which encompasses the watershed of the Chesapeake Big River, now commonly known as the Ottawa River. The Algonquin Anishinaabe have been here in the watershed for thousands of years, long before European contact, and will continue to be here well into the future. I, who was given shelter here in Canada on Turtle Island, am grateful for the hospitality and generosity of Indigenous peoples in welcoming the exiles of this world, and I commit to returning this greatest of favors by doing justice and atoning for all that was and continues still to be perpetrated. Speaking about homelessness mortality always invites our reflection on the fact that this glorious nation and country is founded on a lot of people that were unhoused and then dead, and keeping that context in mind. So I want to be very, very short so as to optimize the time for our amazing presenters and what they have to share. I want to start by kind of homelessness mortality data and the mission of housing all unhoused people in Canada. In CAEH, we insist to only ask questions through that lens. We are interested in homelessness. We're interested in all of those questions, always from the perspective of solving homelessness, ending homelessness, by which we mean housing unhoused people. And so we really want to ask, how is homelessness mortality data helping this mission? How is that serving it? What's the point from that very particular perspective? So how may quality data about the people who died while homeless informs the efforts to end homelessness in Canada? Now, as the notion of people who died while homeless is important, as we will say in a minute, homelessness in itself is not a direct cause of death. We are not saying that these are people who died because of homelessness, because that is not an accurate description, and in fact not gives the proper place to the complexity of the issue. So these are people who died while homeless. What are the direct causes of death for people who die while homeless? What missed opportunities for saving those who ended up dying while homeless can we identify? Who are the people who die while homeless? What predictors of dying while homeless can we identify? What does comparative mortality rates analysis between communities, subpopulations, periods, services accessed and utilized, context of dehousing teach us? Now, all of those questions are very important questions, helpful questions, which we currently cannot really answer because we don't have quality homelessness mortality data. But having quality homelessness mortality data will exactly enable us to do this work, to have evidence-based answers to those important questions, and to translate this into actionable interventions, policies, and things we can do so that no one will die while homeless. But there are challenges, right? There is a reason it's not being done, it's not happening. So these are just some of the challenges, and in the Q&A it will be great to unpack and talk more. So experiencing homelessness, as we said, is not a direct cause of death. And that is a big issue if you want to capture this data and report on it, because that's not an actual direct cause of death. It raises a lot of questions with regard to overlap with other categories, with regard to whom has the authority to determine this is the case, how do we define, and so forth. Death is not hopeful. And we are in the business of holding hope so that people will continue to insist on ending homelessness. We want to insist that this is not a given that forever will remain and that we should accept it as part of life. You know, there is common cold in the world, there will always be common cold. There is homelessness, there will always be homelessness. So we insist, no, homelessness should not be, and it won't, because we will end it. We will get to a place where homelessness is only ever rare and brief. But talking about death does not inspire hope, and we don't like things that are not hopeful. Also, makes people uncomfortable. It's a rough conversation. It doesn't have those ingredients that make us talk about stuff, and we want to think, how do we package this subject? How do we find the right tone and the right note to do that? As we said, overlap with other contexts of interest for mortality data tracking, above all substance use. And like everything, whose dead people are they? Are we stealing from the people who want to report on substance use related? Are they feeling this is taking from our impact by kind of counting them as well? Those questions which often will make us feel uncomfortable because we think, yeah, that's not a good way of looking at it. But bizarrely, people do have those conversations. One big challenge is that it requires linking distinct data systems, above all health data, but also by name data, that are hard to link without compromising confidentiality. One of the bigger challenges, how do we get to a place where we can link data sets while maintaining confidentiality and privacy, above all health data? And we will hear much more about this in a minute. One issue that we haven't spoken enough about yet is that the subject indicates the inescapable need for palliative homelessness response. Growingly, we do see the truly unacceptable phenomenon of elder adults who are experiencing homeless and populations for which the response and services needed are really palliative in nature, which is not something we have unpacked and kind of confronted, and to the extent that such services are being developed, they're being developed without announcing it, without attracting too much attention. There is something people are very disturbed by this, which is yet another dimension. I want to share two resources, both of them from the US, where a homelessness mortality working group in Johns Hopkins University. So the lower one is for the working group itself, and they have lots of resources and interesting material. Above is the toolkit that they developed for collecting homelessness mortality. I'm not saying it's perfect, but it's a start. And let's build forward. And so looking forward to truly two amazing papers that will, for the first time, discuss this subject here. And in the Q&A, really looking forward to also talking together about ways forward, and so forth. So without any more delay, I want to invite Caryn, and I think best if you want to kind of present yourself, and yeah.
Okay, so let me try to put the technology up first. I need glasses now. Oh, all right. And do I hit one of these? Wow, it worked. All right. Really nice to see everyone here today. Thank you for coming to this session. I know there's a lot to choose from, so I'm really pleased to have a full house to talk about this really important issue. Oh, I'm supposed to be at the microphone probably. So my name is Caryn Thompson, and I'm a Policy Development Officer at Toronto Public Health. And in that role, I'm the lead for data collection and reporting around health outcomes for people experiencing homelessness. So today we're talking about deaths and the work that we're doing in Toronto, but we also do some work around births and healthcare utilization, some other data collection initiatives that we're part of. In my role, I'm dedicated to trying to do the best quality data collection and reporting to be able to inform public health action, which includes service delivery, policy development, and program planning. I'm really honored to be here today to talk about the initiative at Toronto Public Health. I think this work is really important, and hopefully that other jurisdictions can also learn from what we're doing in Toronto. All right. Okay. So the objectives of today, I'd like to share and provide an overview of what Toronto Public Health is doing in terms of our deaths of people experiencing homelessness. This is a fairly unique initiative, and we'll also hear from Hamilton, in the province, but also in the country, for collecting and reporting out on deaths of people experiencing homelessness, not just in the shelter system, but in other locations around the city. So I will share information about the genesis of this project and how it works and recent developments. One of the developments that's fairly new is the Office of the Chief Coroner of Ontario has recently started sharing reports with public health units on deaths amongst people experiencing homelessness for which the coroner has done an investigation. So this is an additional data source that has been provided to public health units. And I'd like to share some of the insights that we've gleaned from this new data and how we're incorporating it into our system, and also feedback we've received from the community and how we're changing our data collection and reporting. And dovetailed with that is discussing the challenges in doing this work, and also want to share some learnings in case other jurisdictions would like to replicate this work. So I hope this is what you signed up for when you came today. Like most sessions today, I think it's really important to start with the land acknowledgement. As I mentioned, I'm from Toronto, and the City of Toronto acknowledges that all facets of its work are carried out on the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit and Métis people. These territories are currently covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississauga and Chippewa bands. I also want to acknowledge my own privilege as a settler, as a cisgendered, able-bodied, economically financially stable person, and the privilege that I have to work and live on these lands. Although I have been working for quite a few years now with health data on health outcomes for people experiencing homelessness, I do not personally have lived experience of being unhoused. I think that a land acknowledgement is an appropriate way to start this discussion and this presentation. We know that, that Indigenous people experience homelessness at a disproportionate rate across Canada. And the information that I'm sharing today does not cover how Indigenous identity is associated with deaths of people experiencing homelessness. We know that Indigenous identity is an important determinant of health. And when this data collection initiative started back in 2017, we did ask about Indigenous identity when collecting the data. But the question was, because we have, and I'll talk about it later, we have a community reporting tool. But the question was often left blank or unanswered in over 70% of the time of the cases. So we weren't able to report out on that. And so in 2023, we actually removed the question from our survey. But one of the ways that Toronto Public Health is committed to the calls of the action in the Truth and Reconciliation Committee report is to collaborate with our Indigenous partners to improve the quality of the data that informs public health action. We are committed to our Indigenous partners maintaining ownership, control, access, and possession of the data that can inform health and social services. I'm going to go to the next slide, but I'm also going to grab my water. This is a really heavy topic. Everyone, I'm sure, in this room has been impacted by knowing someone who has died while experiencing homelessness. I want to take a moment to honor those that have passed while experiencing homelessness, often dying prematurely and by preventative causes. We know this from our data, that many of these deaths are preventative. And although our data, and I'll show some of it later, is reported out in aggregate numbers, that these are not just numbers for us that work on it. These are someone's loved one, someone's child, friend, sibling, parent. And I want to take an opportunity to honor them and remember them. Just take a short moment. All right, and I also wanted to share a bit about the motivation behind doing this work for me personally and as an organization. I'm including this poem that recently my manager was at a meeting around collecting race-based data. This is a topic that our team is working on quite diligently around responsible ways to collect race-based information. And they did something really interesting at this meeting. It was a full-day workshop where they had a spoken word artist by the name of Gregory Frankson, listen for the whole day. And then he, in the same day, within the same 8 hours, wrote some poems. And I thought this Policy Nirvana one really speaks to why we collect this data. I won't do it justice, but I will read it. Without the data, we don't have the basis. And without the basis, we're stuck in stasis. And if stasis is the basis, then we'll miss them with the system. If our system's stuck in stasis, is it a mystery? We miss them. And it speaks to why we collect this data, to give voice to the issues that are impacting those who are often silenced, those who are marginalized and oppressed, or not captured appropriately in our traditional data collecting and reporting systems. So a little bit of background is, just a show of hands, are anyone in this room familiar or used or seen Toronto Public Health data on people experiencing homelessness? I see like 4 hands, 5 hands. So I'll give you a bit of background. So this work is motivated from a 2016 Toronto City Council motion that directed city staff to collect all relevant data related to the deaths of homeless individuals within and outside the homeless shelter. And really the motivation for City Council to pass this motion, it came on the heels of 2 very high-profile deaths in the community of people experiencing homelessness, and these deaths really caught the media and the public's attention. One was an individual who passed away in a TTC bus shelter, and the other was someone who died in a shack that had been, it was the structure caught on fire. And so both these people were sleeping rough. And at the time, there was an acknowledgement, at the time, Toronto reported out on deaths of shelter residents. And there was an acknowledgement that not all people experiencing homelessness are accessing shelters. So it needed to, this was an undercount of how many people were passing away, and that just the shelter data fails to capture all the deaths outside the shelter system. So we were tasked with coming up with a system to try to capture the deaths that were outside of the shelter system. And my predecessor at the time, a woman named Joyce Bernstein, engaged with community and consulted with the best ways for public health unit to collect data on deaths of people experiencing homelessness, and worked in partnership with community to create a system that would work. And that a component of that was a community-based survey, a link to a check market survey at the time, that people working in the unhoused population could submit reports to Toronto Public Health. Okay. So not only was the previous system of just reporting out on deaths of shelter residents an undercount or an underrepresentation of what was happening, there wasn't any information on cause of death. It was just a number. The information would be the number of shelter resident deaths and the age of the average age. So there wasn't any information on cause of death. So the purpose of Toronto Public Health's collection and reporting initiative is to provide a more accurate number of number of deaths and information on the cause of death for people experiencing homelessness. And having this better quality data allows us to understand trends in mortality in the unhoused population to inform appropriate programs, services, and policies aimed at improving the health of people experiencing homelessness. And so it really, without good quality data, it's easy to kind of sweep issues under the carpet. So having better quality data can often challenge stereotypes and preconceived notions. So previously, on city council and in the public, there was a perception that most people experiencing homelessness that died while homeless was they were outside and they were dying of hypothermia. That was sort of the thought process. When we started doing the data collection, and the first year we presented the first year of data, the majority of people actually died indoors, and hypothermia is actually not a significant cause of death. That first year, a third of the deaths were drug toxicity deaths. And then the second leading cause was cardiovascular disease, and the third was cancer. So, we're looking at chronic diseases that are not treated properly and are leading to premature deaths. We also know that the median age of death is somewhere between 20 to 30 years younger than the general population. So just a bit about how, sort of the nuts and bolts of how we do our program. As I mentioned, we started in 2017, and for the first 6 years, we had 3 sources of data, and then I'm going to talk about this new data source. So in addition to so one of the benefits in Toronto is that our shelter system is under the same umbrella as public health. So the shelter system could share with public health the reports of shelter resident deaths. And so we receive those quarterly from Toronto Shelter and Support Services. And in addition to the quarterly reports from the shelter system, we have these community reports. So partner agencies and individuals serving the unhoused population have access to this secure online form and can submit reports to public health. We also get monthly summaries from our Toronto Homeless Memorial. And we combine these sources together, and it sort of speaks a bit to what Jonathan was saying. As a public health unit, we have the ability to house this confidential information. So we cross-reference the 3 sources, remove duplicates, and then report out. And And in the past, we also had a relationship with the coroner, and we would send the list of names we had to the coroner, and if the coroner had investigated that death, they could confirm cause of death. As of February of this year, we now have an additional data source. The coroner, Office of the Chief Coroner of Ontario, is now sharing quarterly reports with all public health units in the province of line list data for coroner investigated deaths amongst people that they've classified as experiencing homelessness. So this is a new source of information for us at Toronto Public Health and also public health units across the province. So what does it look like? So I'm an epidemiologist by training, so I love Venn diagrams. And so I've developed this Venn diagram just to give you an illustration. None of each of these data sources is comprehensive. So the community might have reports of deaths, perhaps in encampments or people that are couch surfing, that we don't receive from the shelter system. The coroner can have reports of deaths that we don't receive from any of our other sources. So none of them are comprehensive, and they often overlap. So this Venn diagram serves to illustrate the different data sources and their overlap, as well as the acknowledgement that the system is not comprehensive, and that there are likely deaths that even with all these data sources, we're still missing. So the red section here, I've tried to signify, these are deaths that we still might not capture. Individuals who passed away in hospital, who are inactive shelter residents. So if someone is admitted to the shelter, they become they've admitted to the hospital and they become an inactive shelter resident. We don't get any data from the hospitals. So if that person dies of natural causes in the hospital, we wouldn't know about that individual. Individuals who are not accessing the shelter system, for instance, sleeping rough or couch surfing, who are not connected to any community organization, those would also be people we would likely miss. And another potential gap is deaths that are investigated by the coroner, but that person is not deemed homeless. So if the coroner does an investigation and they find that the person was staying at an apartment, they think the person was housed, even if that person maybe was couch surfing. So what is the impact of this new data source? So as I mentioned, Toronto Public Health used to get three sources of data: shelter deaths, reports from the community, information from the Homeless Memorial. But we have this new source of data from the Office of the Chief Coroner for Ontario. And what we have learned is, our suspicions have been confirmed, is that we have been underreporting the number of deaths of people experiencing homelessness. Also, just a note, to reiterate, the coroner only investigates deaths that are sudden and unexpected. So they're not investigating all deaths. So just to reiterate that point. So we always knew that our system wasn't comprehensive and that it wasn't capturing all deaths. But we now know we have a better sense of how much of an undercount it is. So we're still working on incorporating this new data source into our reporting system, but I can tell you that preliminary analysis indicates that the number of deaths that we're reporting for 2022 and 2023 will likely increase by as much as 70 to 80%. So as an example, last year we reported out that there were 150 deaths of people experiencing homelessness. That number is likely to be closer to 280. So the situation is more dire than we had previously reported. So some of the challenges, I'm going to talk about some of the challenges, and Jonathan had mentioned some of these before. This is really messy data. It's the best that we can do, and so it's better than not doing it. But as an example, for our community reporting tool, sometimes we just get somebody's nickname, we get an approximate date of death, an approximate age, something like that they heard of a death in an encampment. So it's the best that we can do, but with having incomplete data, it does make us challenging to either get more information from the coroner or to be able to rule out duplicates. So yeah, it makes it challenging to match the coroner data, to remove duplicates, or report out on certain variables. For instance, cause of death is missing in about 20 to 25% of the cases. Another challenge, which I think is a good challenge, is that this work really relies on solid connections with our community. We know, looking out at this audience, if you've been working frontline, there has been a huge staff turnover during and after the pandemic. So that impacts, my ability as working in public health to know who's working out in the community, who can I connect with, and also the ability of those community agencies to connect with people in the unhoused community, to know, to learn about a death, to know what's happening in terms of perhaps lives lost. So if someone doesn't learn about the death, then that death will go unreported. So we know that has happened. So as part of ongoing improvement on this project, we recently undertook a community consultation as part of a quality improvement program or project to try to strengthen the system to collect this homelessness data. So we ran a couple focus groups and sent out a survey to our community partners who provided feedback on ways to improve our data collection and reporting initiative. Wasn't so shocking to us that we need to work on increasing the awareness of this initiative. Even people working in Toronto weren't aware of the reporting tool. So we brainstormed ways to improve our connection with our neighborhood or with our community partners. One of them being identifying a designated person at each agency who would be responsible for reporting. And we're also making improvements to our community reporting tool. So broadening the definition of homelessness, updating certain categories such as gender that we were asking in kind of a dated way about gender, and including more specific categories for location of death. So what we heard strongly from our community partners was they wanted a sense of not exact location, but kind of the setting of death. Were people outside? Were they in public transit buildings? Were they in private residence? Were they in the shelter system? So we're working on including that information in our dashboard. What I didn't mention before is that also, so we report out on all the information that we have on an interactive dashboard where people can access and download the data to use it for advocacy or program planning, whichever way they want to use it. So we are looking at expanding the information shared on that dashboard to include setting of death. Okay, so, next slide. So trying to end on a little more of a positive note is that I think 5 minutes. Oh my goodness. Okay. There have recently been other jurisdictions that have reached out to want to do similar work. In an ideal world, there would be a coordinated system that does this across the province or across the nation. If I had my birthday wish, it would be one of two things. Either the coroner investigates all deaths of people experiencing homelessness, or housing status is put on the death certificate so that we would know the cause of death for every single person in the country. That's my birthday wish. I don't know if there's any Tinkerbells out there who can come up with that solution. But what I have been heartened by is that there's lots of other jurisdictions that have reached out to us at Toronto Public Health to find out about how they could replicate this in their community. So I've compiled kind of what I think the keys to success are. This work wouldn't have happened if it wasn't directed by our city council. And city council wouldn't have directed us to do it if community and the public and the advocates hadn't push them to do it. So it's a lesson that advocacy and advocating to pushing the public, pushing our city councillors can have an impact. And we, as I mentioned, this really requires a strong commitment, strong connection to community. So having this community development approach, not only with a strong relationship with our community agencies and ongoing engagement, right? This needs to have a trust between public health and our community partners for them to know me, know us, that they feel comfortable to use this tool to report. What we've heard is it feels exploitative to keep having to provide information and data to different people, right? We're constantly being asked for data. So really the time needs to be put in to make sure that there's a good connection and trust built. And there also needs the collaboration with other levels of government. And for us, we had a very strong relationship with our coroner, an existing relationship. And I believe that is what has pushed the coroner to now share these reports with all the public health in the provinces. As I mentioned, we're fortunate in Toronto to have a centralized shelter system. So that mandates reporting of shelter deaths. So I know there's other jurisdictions that the shelter system is a bit more piecemeal, so that makes it more challenging. We at Public Health are health information custodians, so we can have personal health information, which speaks a bit to what Jonathan was talking about, linking data. This is possible for us because we can maintain confidentiality. And there are dedicated resources at TPH. My role is one of those examples. So I probably am out of time. So actually, I think I'm done, but I just want to mention a couple other projects I mentioned off the top about other data-related projects we're working on around healthcare utilization and birth counts. We do a similar project around births to people experiencing homelessness, which is also very underrepresented. You can catch me anywhere in the conference if you want to talk about those initiatives. And then this data is used to inform public health action, and we have seen the data used in Toronto to expand our programs, particularly around harm reduction and shelters. So I've just listed a couple on these two slides. We'll make the slides available with links to the different initiatives. So I think I'm right on time. Well, 1 minute over.
Thank you, Caryn, so much. And without delay, I want to invite Gessie.
Just got to pull up the thing here. Oh, where's the cursor?
Oh.
It's disappeared.
Oh, there it is.
Yeah.
And yours is in the top. Yeah, right.
Which one?
Yep.
Yeah. No.
You go to slideshow, maybe?
Yeah, there's a...
There you go, from beginning. Bam. Wonderful. Hi. There's a lot of people in this room. I have a bit of a cough. I'm hoping it'll stay back when I'm speaking, but I'm masked for this purpose also. So this is going to be a lot, I think, because I think this work is a lot. So I'm just going to start. Woo! It went off.
Oh, no.
Did you break it?
I didn't touch it.
No, there it is. It's back. Wait, do you have your notes?
It's okay. It's red for some reason. It wasn't when I made it. But here we are. Did I do that with my book, maybe?
Possibly.
Yep. Is it good?
No. There we go. Now it's back to right.
All right. Start my time now.
Yes.
So this is really informal. I'll tell you a bit about me and some of my actions working as a part of the housing and homelessness system. I hope we can think about death in relation to in and outflow and housing and homelessness system success. We're going to talk about the ways that data can be very tricky. That's a very polite way to say that, very tricky, with some brief examples. There'll be lots of examples, and so this is where it's going to be a lot, I think. Describe the Hamilton Homeless Mortality Data Project, of which I'm a co-researcher, and make some requests of you, should you be willing. So, I worked in the housing and homelessness service sector in Hamilton for several years, primarily in family homelessness and then with couples living in encampments or in COVID-funded overflow beds at the height of the COVID-19 crisis. This includes shelter diversion, homelessness or eviction prevention, in-shelter housing work, rapid rehousing, and intensive case management programs. Because of the number of programs, it's also hard to breathe in this mask. Because of the number of programs I have worked in, I've supported families with children to find and secure housing at one end, often at 80 to 90% of their income, often in less than desirable units with some pretty awful landlords and highly visible to children's services, only to then, a year or two later, work with the same people, now a couple, without children living encamped. Some were happy to see a familiar face, and some told me off reasonably, I think. Housing First programs continuously, at least the ones I participated in Hamilton, continuously promise housing for people, but in reality, the programs there anyhow have no meaningful access to rent geared to income or affordable options. This means housing programs rely on the private market to resolve homelessness. The private market, motivated by profit, is deeply incentivized against housing poor people. A large part of my job involved trying to persuade private landlords to choose someone who had been homeless for some time, without references and limited income, to rent to them instead of someone else in the community. I have, as a worker in city-funded housing and homelessness programs, negotiated tenancies with many of the landlords responsible for above guideline rent increases and rent evictions. In my previous work in eviction prevention, I saw families struggle through raining cockroaches, bedbug infestations, mice and rats, no heat, water, rotting floors and ceilings, and abusive landlords. Many of these people just wanted to raise their families, and many become homeless because they understandably could not take it or afford it anymore. I housed these families. One last point, I guess, that I've done is I've provided successful housing stats on the fly to program managers and directors being called by city officials only to see those stats misrepresented and printed in news media to rationalize encampment displacement. I could go on about a lot of things that I've done, not from guilt, because I think it's important. So the idea of ending homelessness, this is kind of what I said for coming to this conference via the concept of functional zero, for example, that measures the number of people entering homelessness and exiting homelessness, presupposing that an equilibrium between them, less entry, more exit, for example, is understood as a major marker of success for localized housing and homelessness systems. This is kind of how this works there. There are some exits from homelessness measured as success that aren't necessarily positive outcomes. For example, some diverting can create the context for couch surfing or overcrowding, risking people's tenancies, while still appearing as an outflow success despite also being known as hidden homelessness. This happens sometimes in shelter diversion, specifically. The same goes for death. As an outflow, it can be misunderstood as a success too. You probably have seen this before. It's the housing continuum. I'm bringing it up because now we're going through some data systems is what's kind of happening here. And I feel like the idea that comes with this is usually this idea of housing system health. I feel like housing system health must be understood as the health of human beings. Ideas about creating flow through the system are examples of benchmarks that can really erase real humans, from proposed recommendations. I think there's a danger in poor math. It creates a set of longer-term problems that, for all kinds of reasons, will not please anyone, regardless of what any of us thinks about people living without housing. I've requested at city delegations about encampments that instead of using this data over and over to measure success, we also need to calculate and estimate the anticipated shortfalls of service provision based on populations turned away vis-a-vis funding allotment, beyond measurements of system success, to take account of the unserved people, the people that could end up and are ending up in parks while money is being spent. So I put people here because, while benchmarks and goals are important, recommendations need to move beyond aspirational slogans to address the health and well-being of actual people and communities impacted, I think. For instance, when we talk about housing, we're talking about people. Separating human material need from the material resource is confusing. Similarly, I've noticed this kind of talk in relation to encampments. Encampments are not tents, although that's part of what's visible. They're human beings. We know that we lack the housing to meet the goals of Housing First, but we continue to promise it through city-funded programs, at least in the city I worked. Without available housing at the outset, these programs can be like obstacle courses. Without actual housing attached to these programs, they can be seen as creating trauma and manufacturing vulnerability that is then falsely described as inherent to homeless people. And this is sadly evident in our politics, media, and community conversations. Instead of recognizing it as products of the flaws in policies and programs being used. If there's no housing for the human beings participating in housing programs, making them jump through hoops, recording the steps taken, and measuring success with the hope of housing in mind is dishonest and cruel. So this is where it's going to get messy because I'm not going to explain all of this, but I'm going back to flow through the housing system. Again, it's a strange and inadequate way to attend to real people. Even if we take a broader look at the National Housing Strategy, we can see that the housing meant to be built in this stream, right here, the land stream, that would be the CMHA, no, CMHC, thank you. I always get them, I hate acronyms. The one in this stream here that's meant to be built is not connected to the bodies under development in this one here. And reports from the Auditor General point to a very similar issue, albeit using a different set of words to do so. The roadmaps, pathways, entries, exits described in evidence-based housing interventions like these, and the categories of people created through Reaching Home and the National Housing Strategy seen as necessary to measure success are exhausting, dehumanizing, sometimes deadly, and harken back to eugenic population science, allowing for us to miss valuable information. That's rough to hear, I know, and I know it's like there's a lot being shown here, but I want to say it. So valuable information and to listen. Listening and taking people's needs seriously rather than measuring people as flowing widgets alone is important. Much more nuance is needed, and I think we also need to think about how we talk about people, even when the language is built into our evidence-based tools. Chronically homeless comes to mind. Broader ethical considerations aimed at attending to known and lived realities of increased risk of isolation, harm, and death for people without housing need to be considered alongside an attention to historical projects of eradication, death, to reveal possibilities for intervention. So for instance, I don't know if anyone's ever seen this. This is from a book in the early 1800s called The Feeble-Minded in Ontario, from the Office of the Inspector of the Feeble-Minded. And so, you know, it was a very popular idea, and is a population science that was respected and is still visible and ongoing in policy, practice, and law, used as science for improvement, and talks about people and where to put them as a means of legitimized eradication policies. This kind of writing became less popular, I suppose, during the Second World War. You know, I'd love to be able to read some of this to you, but I will run out of time. I think notably is, you know, down here, the Mental Deficiency Act, hang on. We now know that the greatest cause of feeble-mindedness is heredity. Legislation to improve the housing or the feeding or anything else about the feeble-minded is useless. The root of the matter is to prevent their birth. So this was a policy meant towards making sure, if you were to read and you read the entire thing, it's eugenics in this case was about making sure people couldn't procreate, couldn't have children, and other things. Here is, goodness, the PASS system. An example, I guess, this is the way I've worded it, of the placement of people within a housing or settlement system. In this here that you can't read all that well, I've kind of pulled a piece out for you. What speaks to me here is like about the criminalization, if you were able to read that piece, that there wasn't much of a choice like we speak about now either, that there's a ton of surveillance. This is a document that's to the police about how people can be charged or moved along, how Indigenous people could be moved along if they're not living in reserve. through other laws like vacancy laws and prostitution laws. I'm sorry, I'm going to cough now. Oh, this is rough, eh? I think I would just ask, I think we have a history of clearing the land of problem populations to progress. These histories have often involved policing, social work, religious organizations, and politicians, and others. Social workers participate in these activities, of which I am. These things also do not land equally. If you look at the populations disproportionately represented in homelessness data, for example, Indigenous communities that were mentioned by Caryn earlier, you can start to draw very upsetting conclusions about the living legacies and current laws, policies, practices, and programs. Not as though it's something that happened over there, but maybe it's something happening now. Both. So basically, what I'm saying is stories and conclusions that point to, cost-cutting, neoliberalism, capitalism, policy turns like housing divestment without consideration for larger projects of nation-building, conquest, colonialism, the wielding of land to make an ideal public. As ongoing legacies, they need attention. The story we tell ourselves about it being different this time, I don't think are good enough anymore. Oh, this one's about me. So this is my hometown. That's the open pit mine in the middle of it. Over here is not. That's the only one in the bottom quarter. That's Alschech, if you're familiar at all. I'm from a mining town. So I just wanted to bring this in because I think these conversations are also made possible by similarly fashioned ways that lines and borders are drawn into land. As I mentioned, I was born and raised in Timmins, a northern mining community, where the degradation of land for wealth extraction draws lines into the surrounding landscape. These lines have displaced, divided, and exploited as a matter of wealth, conquest, and nation building. These understandings, the way they're lived and felt, the way they define human need and risk as problems to be managed rather than important realities of living in relation to each other and our environment, haunt and inform my work in housing and homelessness. They make me skeptical of the tendency to confine knowledge on homelessness to data points, and then to point to, for example, NIMBYism or neoliberalism, again, deinstitutionalization, drug use, social housing divestment as the cause and the beginning for the problems. And so all of this together, I speak on for a few reasons, like from the beginning to now. In part because of what I witnessed, previously participated in, because of the people I was fortunate enough to get to know as a housing worker, the service users. Sorry. Because of non-disclosure agreements and confidentiality, housing workers are rarely able to speak about what they see and do as part of their daily jobs. No. I was one of those people. For me, this inability to speak about what is seen in the work plays a role in my research on the Hamilton Homeless Mortality Data Project, where for the past 3 years, we've collected, myself and a team of doctors and some students, have collected and made available reports about people dying while experiencing homelessness in Hamilton. And while on most days I feel as though this is a terribly inadequate way to honor and respect the lives of people who have likely and will continue to die, the exploration of death as a potentially uncaptured outflow in homelessness data collection is an example of a strategy and actionable knowledge that I hope helps to reveal even just a small sliver of gaps in the evidence-based collection record. So, the Hamilton Homeless Mortality Data is an unfunded community-based initiative that collects and disseminates data about the deaths of people experiencing homelessness. Since our initial report in June of I don't know if that's true, June of 2021, we began in the spring of 2021. The project has endeavored to make known mortality risks faced by members of our community deprived of housing. It's collaborative and it's a co-led project. All members that work on it currently work and or have worked with people experiencing homelessness in the Hamilton community. With approval from the Hamilton Integrated Research Ethics Board, The project is possible through the participation of community partners, including shelter workers and community agencies. And so this is anyone who is working around with, alongside people that are experiencing homelessness. Oh, excuse me. We'll get there. Whew, and that's via an online anonymous survey. And relationships that include a bilateral data sharing agreement with Hamilton Health Sciences and St. Joseph's Hamilton, which are hospitals in the Hamilton area. So unlike Caryn, who does not have hospital data, we do as a part of having doctors on our project. And also our community piece is a little bit different as well. But anyhow, so we have different kinds of data sets than Toronto has. This project originally began as a health and social service response to a noted increase in health for people deprived of housing at the height of the COVID-19 pandemic. In that terrain, isolated workspace pockets, I'm not going to read this. I'm going to say in that terrain, when I was working, we were all talking to each other and everybody else was in their houses, it seemed. And everyone we were working with were dying at like much faster rates. And we were now like coexisting in these ways we hadn't before. And we were just like, how is it possible that everyone around us is like that this is the work we're doing right now? And so with that in mind, we were like, okay, we need to do something better than this. There's more context than that I'll mention later, but this was a response not only to like, wow, that's very sad, but also we weren't coping with it either. That's a real thing. These are people we knew, people we got to know, and we were meant to be their caregivers. Help and care should look different. So I'm going to skip what I wrote here, and hopefully I don't miss anything. But I'll say this. It has been repeatedly demonstrated that homelessness is associated with decreased life expectancy. From the outset, this has also been evident in our project, where the current average age of death for those experiencing homelessness in the Hamilton community is 45 years. We've also found that on average, since December 2021, one person experiencing homelessness in Hamilton died every 10 days and continues to. And this is definitely an underreport, just like Caryn said. We know that we're missing tons of stuff. At this time, we've learned of 116 people who've died. These deaths represent entirely preventable modes of death that must be addressed, and our data collection and dissemination is conducted to support these ends. While the information we collect is used by reporters, city staff, local politicians, and activists, among others, to inform policy and push for changes that may reduce harm, the project is also aimed at providing a space to witness and speak to what is seen, yet often rendered invisible. Remember, I talked about not being able to speak when you're doing your work, not being able because for the fear of confidentiality and those kinds of things. This is what I'm talking about. The things we weren't able to speak that should be spoken, I think. The project is also aimed at providing a space to witness and speak to what is seen, yet often rendered invisible, in the everyday lives of people living houseless and those who get to know them through service provision. Whew. Hang on, I want to skip over a part. So this has meant, especially with our community reporting, that we needed to connect with individuals, workers, people outside, people working with people outside. Right now we have permission to speak with people working with people. Sometimes on a one-to-one basis as the person who does receive these, who works to gather people to answer the surveys that are working in these places. That often requires a lot of work around mourning and talking and becoming aware of a lot of things. We want to ensure that we actively value the passion held and experienced by members of the broader community. While arguably inadequate in attending to needless death, anonymous survey reporting is often the only place that many housing and homelessness workers can speak about what they see and hear in their everyday work. In short, the biannual numbers reported as sanitized data represent more than what is seen by the public. Again, we do compare this against hospital data as well, like just to answer that question, so that when there's duplications in a similar fashion that Caryn had mentioned with the community reporting, but with coroner data. So I'm going to skip through because I don't have a ton of time, but I'll go here. I'm going to say that so far we've made 6 reports publicly available on a biannual basis. All of our team members work to create a media release that includes the raw data collected, a general contextualization of what the data speaks to vis-a-vis funding and known practice realities, and an intentional statement of political engagement or a call on policymakers in the Hamilton community to directly contend with the data in tangible ways that acknowledge each number as a human being. Each data release requires that we prepare and make available members of our team to speak to media outlets with the aim of providing the data found while also highlighting what, through our community partnership conversations, we see as gap in public and political information. So here's some of those headlines that occurred. We've seen it taken up in many ways in the news. Fires, cold temperature, anything you might see here. Also, our team strategy is to collect information accurately and ethically while simultaneously speaking about the findings in a direct manner to invite broader consideration. It's understood as an important aspect of its design to impact, support, and inspire change through engagement and prompt discussions about meaningful care and action outside of the confines of professional level guidelines that can impede community transformation. I'm supposed to tell you about pushback now. I wanted to, and there's a lot of context to provide here, but I won't have the time, so you can ask me in a question if you like. I will say briefly, one context is the City of Hamilton is currently having a charter challenge. So there's a lot of things going on in the City of Hamilton that creates a far more tense situation than, for example, if I was working at public health like Caryn does. So my concluding asks. Most of them are written here and not written there, so I'm just going to read them to you, and they're kind of point form there. So, as you go to other panels to learn about proper data collection, how to access funds by doing proper data collection, and how this all feeds into a potentially self-enclosed understanding of the problem and solution of homelessness via aspirational goals, I ask that you remember and take with you what is not being described, what is left out, that you take what I've offered here, think about it in relation to what you know about your work, and ask really good questions. Then, in terms of a personal reflection, I suppose, on an individual level, regardless of your discipline, whether you're a politician, a policymaker, a social service organization manager, working in mental health, a housing and homelessness worker, a city planner, someone living outside, precariously housed, or otherwise, I ask that you reflect on what you want and envision. Reflect on your intentions and aspirations. What you say and what you do on a daily basis that likely leaves much of this out. I do not believe that death and dying is how any of us plan to or want to realize an end to homelessness. I would be very surprised to hear that anyone in this room does not have multiple examples of where they do a different thing than what's being asked of them. We all know that how it is written is rarely what we do. I think it is important to remember that, and I think it's very important to remember that individual acts of compassion do not remedy, reconcile, account for, or respond to systemic atrocities. And lastly, consider measuring shortfalls, even though they're not clearly represented, funded, nor encouraged. Like the current structure of Reaching Home Funds does not pay to measure who's missing out on services, it measures successes, right? These erasures, I think, reveal the importance, like they're good tools of advocacy and intervention. And they're, I think, a little more, like they could lead, depending on how they're designed, to like something that's a little more honest about the reality. So it's like you open a warming center, and you're like, we opened a warming center. And then you're like, but 100 people didn't get warm. Right? Like if you're at the door, you can say turned away, turned away, turned away, turned away. And then you have a sense of that. And that's like just a basic format of that, but I think it's really important. And then also, I think I would ask you to take up your own project that meets the needs of your community. I think they are specific to community, with some, some design similarities. Yeah. So I hope, I hope we can begin contending with mortality as a system outflow for solidarities and advocacy to end homelessness. Thank you.
Yeah. So first of all, really, if you want to join me again in thanking our speakers for truly exceptional papers. Really, thank you so much. Now, this has been a very rich and very diverse presentations on a complex and nuanced topic, and I really want to invite now you guys for a Q&A, and please, yeah. So if you want to move the microphone around, I think it will be easier than.
Testing? Oh,
Yeah.
It is. I just had to get myself. This is a rare moment where I'm not tall enough. There we go. Thank you very much for very important presentations. I'm Caryn Snyder. I'm an emergency physician who sadly does fill out many death certificates. And I was struck as we spoke about the complexity about death is that almost all, I'm not going to say everybody, has a death certificate, a medical death certificate at some point. And we are asked if somebody is pregnant, we are asked if they had surgery the day before. Is that maybe a point, it is almost too simple because there's politics behind it, but is that something we should be striving for? Is that instead of trying to combine 3 different sources and using what is kind of terrible administrative data across the board and asking a lot of people is, you're asking me if somebody's had surgery, why not also say, and with a good definition of what's defined as homelessness, and if people expect, why not ask me that question on a death certificate and just make this all really obvious?
Yeah, I have are these on? These are on. Yeah, so that's something we're advocating for, to have homeless or have housing status added to the death registration process. It's something I've talked to the coroner about. It actually requires a legislative change in the forms to have that happen, and the political will to change that. So I think it's possible, and it's something that definitely we're trying to push. Hand in hand with that, though, we need to make that information available more quickly to inform action, because it would go into vital statistics. And we are years behind getting data for vital statistics. So we only recently, I mean, for the longest time, we only had like 2015 data. So to be responsive to things that we're seeing in the community, like drug toxicity being a higher cause of death, we don't want to have it be waiting 5 years to get that data. So there's definitely 2 pieces. You know, we would end all these piecemeal projects if we could just get housing status added to the death registration process, so we just need the political will to have that changed, and then quicker access to the data once it's available.
I actually can add a little bit to that. Unfortunately, so there are we've had a couple of different doctors. One in particular has been alongside myself since the beginning, and they're internal medicine doctors in the city of Hamilton. And what I've found, because we do pull from hospital records, is that they're being, like, as time is going on, they're being coded in ways that gets better all the time. And so there's also like a local response you can have in teaching and thinking about what gets put on those records. And then, like, I believe there's some work done as a team or on the floor or wherever they're I don't know this part of it, but like there's some work being done because it improves every time. And like you said, with a good definition of what homeless might be also, because we include transitional housing in our, although we don't get many reports at all from transitional housing, way fewer than what I hear about, which is not data. But starting to put those addresses, for example, is a very helpful way for us to be able to gather that information, because then it gets coded that way. Mm-hmm. Thank you for your question.
Hi, my name is Manisha. So I kind of building off of what you said in a way. Caryn, you mentioned that you have different data sources, and I heard you say how the coroner classifies homelessness. And I was just wondering, has it been hard, I guess, to quantify and to really know the deaths among the homeless population because of the classification of homelessness? And is that varying among these different data sources? And if so, what do you think the definition should be and what should it encapsulate?
Do you want to start? Or do you want me?
Either way, go ahead.
Yeah, I mean, we use a fairly broad definition that includes people that are couch surfing. So we use the Canadian Observatory on Homelessness definition for homelessness. So even though people who might be recently housed but had long periods of being unhoused or are in precarious situations like couch surfing, we use that as a definition. I can't speak to the coroner's process, but I do know when they investigate a death, if that person seems to have been housed, like if during their investigation that person was residing in an apartment at the time, they might not categorize. They have two broad categories that we get. It's homeless in a shelter and homeless not in a shelter is what we receive. You know, there could be times where what would be our consideration of homeless, the coroner might not. But we, at Toronto Public Health, we've made the decision that if a community partner has told us that that person is homeless, then that person is homeless, right? So if the coroner might have said that they are housed, we trust our community partners that know that that person has either had long periods of being unhoused or was precariously housed. So I think it's really challenging to have a really concrete definition of what, so we try to use the broadest definition possible, and I think that's, we've had support from the community on that.
Yeah.
Thanks.
Sorry, I think, you know, that just made me think about something I skipped over real quick. So, because, I'm going to add, do you want to go back to the slide that I have graphs on? Can you? Thank you.
This one?
No.
The one before?
This guy.
Yeah.
It's
Oh, it's just not.
Oh,
Yeah.
I think if you press.
oh, yeah.
The,
Yeah, slide shows up.
There you go. So, see, this graph here is a little bit different. We get a lot of rich data from the community survey. And in terms of action, or in terms of trying to think about the ways in which help and care, how we want them to look, how we want them to be, what we got into doing, what it is that we're doing, we ask a few questions of workers. And we don't get that from any of the other data. So for example, we know how many people were meant to be leaving a care facility or a health facility sometimes. We know that information if it was the community report, and tells us all of the systems that were meant to care or help that somebody has touched 30 days before their death. So you can imagine if you touch 4 different systems in 30 days before your death, all of which were meant to help, care, or provide something thereafter, there might be something problematic with that in terms of how we define help and care, or how those systems are functioning, or us within them. So, sorry, I'm piggybacking on that question, but I skipped over this, and I wanted to mention that, because I think in terms of not being just like a data point, I think those are important in terms of reflecting on our work.
All right. Thank you for the sensitivity to which you've handled this topic, really delicate. That said, as organizations navigate change management and organizational transformation, i.e. post-pandemic, I was just wondering if you can touch on 2 points as it relates to psychological safety and trauma-informed approaches as we support our teams. And that's in the context of an organization, i.e. a shelter, having to identify with mortality, a death, and moving through, again, the psychological safety of your team and trauma-informed practice once we've identified what's taking place in the community.
So I can take a stab at that.
Yeah.
But first I want to say, I'm not from an organization. I'm from an unfunded data project. When I worked for an organization, I'll speak to it this way. There wasn't much care taken. I didn't leave that job in a great place. I'm much better now because I'm doing something with it, right? So I think that how we draw lines for care and help, like I'm mentioning, are evident also in those places. And a consideration of some of the things that I mentioned are a way to be careful, to be mindful, to be honest, to be thoughtful about the ways that we treat people. I can only speak for myself in this, in that, like, when I would go to my manager or these places and say, hey, what I'm doing isn't working and these people are getting worse, and it's because I'm saying I'm a housing worker and I have no housing. That's a gaslight. Mm-hmm. And then the manager says, well, keep with the program, right? Mm-hmm. And so it's like burnout is a lot more frequent and possible in that scenario, right? You have a wealth of information in front of you in the workers, if that's what you're talking about, the workers operating and not burning out. Is that what you're describing?
And the context is as someone who, as a part of management, supporting teams, again, through the change management, that being a theme, being able to delicately help individuals navigate trauma-informed and psychological safety. So to your point, however you feel to answer, please.
Yeah, I think the other part is that I'm trying to kind of highlight is, like, I step up my house and I see people living outside everywhere. I don't know how you can be trauma-informed about the conditions in which we're existing and walking around it at all times. That seems to me, and I don't mean to pick apart your question, it's actually a great one. It seems to me like a way to make it my problem. What I'm seeing is not good. What I'm seeing is harmful. What I'm seeing is sad. I can rely on others and people who are doing this kind of work. Working together is nice. Trying to be hopeful, trying to imagine different kinds of possibilities. But, like, where I live, and I don't make a lot of money and never have, and I'm a single parent and all those things. Luckily, I'm a PhD student, which is doing something, I guess, I don't know. But, like, we don't live in a good time. I would be hard pressed, I think, to find a handful of people that would say that. So when we call it trauma or psychological, like, that's kind of putting the onus of the problem onto the individual, I think. As though it's like a mental illness now and not the context in which we exist. So maybe having conversations around that and how that can be felt together would be helpful.
I also really want to thank you for raising this, because in our sector, especially frontline, and as someone who also worked frontline, there is no support. There is no type of what's common in psychology and in social work, like the type of mentorship and supervision, clinical supervision, that allows staff to process, to understand, to do something with the aggregate effect on them. What happens when you work for years and some of your clients die? Some of them are people you really made a connection with, and it's just part of the job, and there is nothing in place to help you process that, and there is no reflection on what does it do to you, because there is only so much grief we can just hold, right? So at some point I'll stop generating those connections because I can't deal with that, right? I can't deal with the grief. So I will become more aloof, more indifferent, more reserved, because I'm protecting myself, sometimes without realizing this is what I'm doing, right? Because there is no situation in which someone invites me to reflect on those things. We don't, and there are things we can learn from. If we look at the HIV/AIDS movement from the 80s, how they managed to give place to grief, to give place to loss. Gestures such as releasing the number of balloons of the people who died since we last did that. Like, symbolic gestures that give place to the fact that this is also part of what's happening. But we've also heard from people in the sector that asked us, so when you submit B&D by name data, the category of inactive includes people who we lost contact with, are incarcerated, are hospitalized, or dead. Now, it's true that death is in a form of inactivity, and it's part of the outflow. However, workers talked with us about the pain of knowing the person whose name we are now reporting as inactive, but we know they're dead. And that feels heavy. That feels that even reporting it as deceased helps a bit, because it gives an honor of place to someone who lacked a home to die in. So to begin with, we are talking about a situation in which human dignity is being pushed to the limit. And so this heaviness and this discomfort, facing it is hard, but it's needed. And it's part of the transformation the sector needs to go through. And the workforce deserves the type of conditions that allow them to thrive and do this amazing work in an extended period, rather than the endless revolving door we have of people coming, giving their all, being burnt out, moving on. So thank you so much.
May I add to that just quickly? Also, I mean, my experience was as a housing worker, I was working with programs and policies that everyone was saying were successful if you just did them right, that actually didn't have the things that you needed to get them done. So there's the reality of that too, which is like, is forget all of the other stuff. It's actually like, I came here with the idea that I'm going to help someone, and I don't have the tools to do that. And we're pretending like we do. So I just wanted to add that as well. That's really tough. That's a tough place to work as a, like, from a manager's perspective, from a worker's perspective, from a community's perspective.
So,
That's real.
no, go ahead.
Hi, I'm Jacob.
Hey, Jacob.
I have a weird question, and I'm not meaning to be like Debbie Downer or rude or anything. It's just, I was homeless for years, and I've been clean for 25 years, and every fucking day I get a message about someone who's dead from my past. How are we going to use these statistics to do good instead of exploiting my family that's still out there? I'm just curious. I'm sorry, I'm not meaning to sound rude when I ask that, so please don't take it that way. I've seen statistics make money, that's the reality of this field, and that I've seen that be used not for the good of my family, but for the good of corporations. How are we going to use these horrifying stats that we all, anyone who works frontline and has believed for years the stats that they give about homeless death, it is like has their head buried in the sand. It's even triple to what you're saying today. So how are we going to use this to actually fucking help? That's it. Thanks.
Thank you.
Sorry.
Thank you, Jacob, so much. And I wonder if the best thing is not really to let what you just said just resound, because just let it resound. Yes, exactly. How are we going to do that? And we must do that. Yeah.
I'll add recently, because there's a focus, and I'm really sorry for your losses. It's a really, sorry, fucked up. Recently, we've been trying to build out into a community project, which means that meeting with people who are living outside, we're making some space to talk about what they would like to see recorded, reported, and brought into the conversation. But primarily, when I talked about speaking one-to-one with workers who are mourning, it involves a heavy focus on making sure that we use that space to be able to support one another and think about how that can happen, and how this tiny little thing, when structured to push toward better conditions for friends, families, people around us, is one reason, rather than just, being like a checkbox that we have that, like, now we're recording that too. and like I mentioned several times in my my presentation, it's, numbers and widgets and bouncing balls and everything else that we equate everything to as flows through things is never adequate. And I appreciate your comment. Thank you. And your question.
Yeah, I would just add to that, Jacob. I'm also sorry for your losses and all the losses. The frustration is, I think, evident for everyone working in this field, right? That we keep collecting the data. For myself, I've been working on this for 5 years. It's not getting any better, and we see the same patterns. So in Toronto, we're trying to institute programs and services that address those key top causes of death, but we know that funding is getting pulled back for a lot of those. So I think the issue of we keep collecting the data to know what the causes of death are in this specific. And, I hope as someone who collects the data that it gets used to have programs that would address the issue. And we know that that isn't always happening. And sometimes we're stepping backwards. So I think, as Jonathan said, to let that resounding of what are we doing, and it's hard because in Ontario, we know that a lot of the programs we've put in place to address the key cause, the top cause is drug toxicity. Those programs are getting rolled back. So thank you for keeping the feet to the fire. And I think when I think about my lane of making sure we have the best data so that people can't ignore that these are the issues, right? That these are the issues that are getting as close to what the reality is in terms of the numbers and the causes, so that it can't be ignored.
I'm going to add quickly too that I know there's another question coming. I'm so sorry that I don't necessarily agree with the opening, respectfully disagree with the opening that housing cannot cause death. I think not having care at a hospital, not having a plan when you come out of jail, not having care in a shelter, all of those are forms of neglect, especially when you have a duty to do those things. And so maybe the death is via neglect and less about, or whatever you want to name it. I think whatever it is, doesn't matter the cause, there needs to be something done about the hopefulness that we have toward doing this work. People want to do it and want to see things doing better, and beyond data points, that's actually what it should be about.
Yeah, just really quickly. So I'm a data professional, but I'm going to tell an anecdote really quickly. Or a story. So unfortunately, we buried my cousin this year who was experiencing homelessness. And, I had to explain to the family that there was no pipeline in the data to quantify what had happened to him. And they were deeply upset about that. And so I just wanted to say thank you so much for what you're doing, and please keep pushing, because there are families who really appreciate that. Thank you.
Yeah, thank you.
Thank you so much. Yeah.
Friends, thank you so much for coming to this session, which was probably not the easiest or the funniest. Hope you continue to have a productive, fascinating conference, and thank you.
Thank you.